typical for this
Rag and let the paediatric anaesthetist know, please.
Yes.
I've got a bit of time.
Yeah. Is that Birmingham?
Hello, Roscoe.
Okay. Okay, what's your ETA? Okay, lovely. Thank you, bye. 12:40 ETA.
Just fall downstairs.
Yeah,
GCS
top
3
level
RSI.
GCS RSI, yeah, they're on Warfree.
Hi, trauma alert. Category 2. Golf Charlie Sierra 3.
This is the new trauma.
So it's a 39-year-old man found at the bottom of the stairs with a low GCS, so he's basically unconscious. Helimed's gone out and intubated him to protect his airway, and they'll be bringing him in. So he's potentially got a severe head injury. He could have just collapsed at the bottom. So propofol, rocuronium, metronidazole, tranexamic acid. You got everything?
Okay, so this is Stuart. He's 39 years old. So he was last seen at about 7:30 this morning. Was then found at 10:30 at the bottom of a full flight of indoor stairs, having landed on a hard tiled floor. Significant pool of blood.
Okay, so we're thinking fall downstairs rather than collapse above.
Yes,
Okay.
fall downstairs. GCS of 3, fixed dilated pupils, tolerating Goodell airway, bradycardic, hypertensive.
Any family coming or anything like that?
Wife is coming. Yeah, we have got a mobile number for her, so she's in the picture of the likely dire prognosis. So.
Excellent. Okay. Can you do a primary survey for me? Just want to get him into scan, see what we're dealing with.
Radiology.
Hi, it's trauma team leader. Can you protocolize the CT for me? Code red pan scan.
Cheers. Split. Thanks.
Cheers. Okay, thanks. Bye.
When's the hypersonic set on?
It should be at the back there. Yeah, give him 250 mils. Thank you. Here's drugs. Volume about 450. Rate is 18. Pressure's 30 on 80% FiO2.
Although the brain is protected by the skull, it's still a really fragile organ. You know, falling down the stairs is going to cause a lot of damage to the brain as it gets rattled around inside, which can be a life or death situation.
All right, CT's ready. So he's got evidence of a severe head injury. He's got what we call battle signs, so bruising to the orbit. He's also got fixed dilated pupils, so a lot of symptoms showing that there's been direct trauma to his head, as well as his physiological state. So his heart rate's really low. So when your brain starts getting squashed, what happens is it causes a kind of negative feedback loop where it drops your heart rate and stuff. So it's not looking good for him. But until we actually get the scan, then we won't know for sure.
Hi mate, we're on the table now.
Is it possible he might need neurosurgery?
Yeah, he's got a definite bleed.
Yeah, so he's got quite a decent volume of subdural hematoma, most conspicuous along the left convexity with mass effect on the adjacent brain, subarachnoid blood as well.
The brain's kind of starting to press down a little bit. There's not too much room for it to continue to expand into. If he keeps bleeding like this, it's going to cause even more damage to the brain.
Yeah.
Okay. Thank you.
Thank you. Cheers.
Hi, can you put me through to the neurosurgical registrar on call, please? He's not well at all at the moment. Our priority is to try and stop the bleeding from getting any worse, which then obviously causes secondary brain injury and worsens his prognosis even further. Can we get 10 milligrams of vitamin K, please? Do you know the number for transfusion?
10 milligrams, yeah.
10 mils an hour, yeah.
Everything we're doing at the moment is trying to optimize like the oxygenation of his brain and keep that blood going to his brain before it gets too tight and cuts everything off. He's not well at all at the moment.
The main problem is that he's got a significant bleed and brain injury, and therefore the team that we really need to get involved is the neurosurgeons, and then it's really up to them how they want to further manage this patient.
If we set up for a catheter,
Just give him 50 over off as well. Breathing.
I mean, he's still fixed and dilated, so even after hypertonic, so All right. Speaking to your boss. Yeah, so what's he said?
So he's seen the scans consistent with a devastating brain injury, and we feel that surgery won't be in his best interest, and it's likely to be a non-survivable injury.
Okay. All right. So I guess we'll just X-ray him, palliate him, see how he does.
On the scan, there's a significant clot that's causing pressure on the brainstem. As a result of that, his heart function is not working normally, and he's being supported by the medication and ventilator at present. I think it's very upsetting, especially he's young. He's only 39. Obviously, we want to try to do our best for everyone, but in this case, we feel that surgery will not change the outcome.
It's always difficult. You always want to do what's best for your patient. So sometimes the best thing to do is do nothing and just keep them comfortable and support them through the final moments of their time here, and just make sure that family are supported and are aware of what's happening. So. Hey, yeah, okay. Mum and wife are here. Obviously, it's a big shock to them. You know, for them, he's a young, fit, healthy individual who's leading a normal life. So, as you can imagine, emotional. As I get older and stuff, you know, I see more and more patients who are kind of my age that have young families like myself, and you start to identify with them and you think, God, like, you know, this is like looking in the mirror. Sometimes you think, this could be me, you know. You just have to take time to reflect and just, you know, make sure that you go home and hug your family and make the most of everything.
All right, coming by land, yeah? We've got a trauma coming in. 26-year-old male's come off his motorcycle, not sure on the speed. He's gone into railings.
Yeah.
They think that he lost consciousness at the time because it was rang through as a cardiac arrest.
Okay.
They're thinking that he's got right arm and shoulder bone injuries.
There's always a critically ill patient. There's always a time-critical patient that needs you there and then. And, you know, it's hard to just kind of go straight back out there again. You need to make sure you're not distracted with the last patient and give your next patient 100%.
He's just arrived.
Riding his motorbike approximately 30 miles an hour. He's lost control, skidded straight into the rail. His bike landed about 20 to 30 foot up the road. This is young Ben, he's 22 years old.
Yep.
Riding his motorbike approximately 30 miles an hour. His friend who was behind him on his own motorcycle said his back end just went.
Oh, so basically he's lost
control. His friend said he was unconscious, noisy breathing for about 2 to 3 minutes.
Okay.
When we arrived, he was conscious, but he wasn't making any sense. He kept repeating himself over and over again.
Okay.
Ben, my name's Ben. I'm one of the other A&E doctors. Let's have a look at you. Does it hurt in your chest at all? A little bit. Nice deep breath in, deep as you can go. Perhaps reduce movement on the right-hand side. No obvious beat problems. Tummy all right, Ben?
Yeah, so what happened?
You come off your motorbike. I think you
Did that
just lost
hurt?
control of it. Your hip's okay, Ben?
Yeah, just my little part of my back hurts a little.
So what's the last thing you remember then, Ben? Do you remember riding your motorbike?
I remember going out.
So it sounds like you got a little bit of concussion, okay. So one of the things we'll do is we'll get a CT of your head, all right? Make sure there's nothing going on there.
So, what exactly?
Looking at you, you've probably caught your
Holy
guess.
shit.
What's sore?
My right arm is got numb a bit.
Okay. Can you feel this?
No, I don't feel that.
Are you able to sort of move your fingers at all?
This right can.
What about?
I can't. My right one I can't.
Can you give us a thumbs up at all?
No, I can't.
When your patient's complaining of loss of feeling or sensation in an arm or a leg, to me that's a real warning sign. One of the big things I really worry about is a spinal cord injury or, a big nerve injury traveling down that limb.
So we're just going to roll you to your side in a minute.
On my command of roll, ready, steady, roll.
Oh, fuck.
Just tell me if it's really sore.
Right.
Is it sore there?
A little bit down.
Yeah.
A little bit, yeah, there.
Okay.
Oh, fuck.
There? In the middle?
Yeah.
Okay. So he's tender probably about T2 to T6. We'll get you some more painkillers. Make you nice and comfortable, right? At the moment, first appears a little bit sicker than I think the original standby message suggests.
You okay, Ben?
It very much sounded like he was potentially just, maybe a fractured arm or something from the initial call, but his observations and the way he's kind of clinically presenting now, it looks like there could be some more serious pathology going on, sort of inside either his chest or his abdomen, as well as what looks to be quite a significant injury to the whole of his right arm, including disrupting his nerves and potentially blood vessels as well.
And the colour of him's horrendous. His blood pressure's dropping.
Okay, we'll get the blood when we come back. We'll just get the scan. Yeah, Cat 2 trauma, 22-year-old male, possibly abdo injury. What we've just done now is upgraded his trauma call from a Cat 3 to a Cat 2 to get more support from the rest of the trauma team. Should we go to scan?
No, not this.
Yeah.
Arm down a bit.
Your arm is flat by your side. Does it just feel a bit odd at the moment? So we're about to go to scan so we can get a bit of a better idea what's going on. All right, lovely.
We're hoping that the CT will show us whether he's damaged the major blood vessel that runs under his collarbone here. That could be one of the reasons why he's so sick and his blood pressure's quite low and his heart rate's quite high. Clinically, it looks like his belly and his chest is potentially stable, but when you have big distracting injuries like this, it can mask more subtle injuries.
Right.
So it was motorbike into metal fence.
Okay,
So
I'm
you're
going to do the
suspecting
scan now.
right
We're almost
thorax.
finished.
So he's got a big kind of swelling mark up here.
Yeah.
And then it looks like query with some sort of brachial plexus injury down the right arm as well.
Breathe normally.
Yeah, as you said, so there's extensive injury predominantly on the right thoracic wall. So that's all subcutaneous hematoma. Scapula's obviously fractured here as well. But I think the big problem is in the liver here. That's extensive hepatic contusion. Yeah, and there is also hemoperitoneum.
Thanks.
Yeah, we can get him off.
Okay.
Thank you.
Cheers.
Yeah, we're on, mate.
Unfortunately, CT's confirmed. Looks like he's got significant liver injury. He's got some bleeding into his abdomen. He's got quite a lot of bleeding from a blood vessel up around his shoulder that's going all around his chest and stuff. Yeah, he is quite sick.
Right hand kills.
Okay, we'll get you some pain relief as soon as we get back in, mate. All right.
So at the moment, looking at his most time-pressing injury, the thing that's really critical for him is his complete transection of a major blood vessel within his chest. And it looks like the nerves have been ripped out from his spine when he's hit that fence. Now, Ben, unfortunately, the scan shows that you've got a few injuries, okay? So you've broken your scapula, which is like your shoulder blade, okay? And you've damaged one of the blood vessels that sits here, okay, under your collarbone, all right? And you've also got an injury to your liver as well.
Liver?
Yeah. So it does look like you're gonna have to stay in hospital for a little bit with us, all right? But we're gonna take very good care of you, all right? Your head and everything looks all right, so your brain's okay, all right? Okay. But you won't be going home tonight. And the surgeons, they'll come and chat to you once they've looked at your scans. and we have a better idea of what's going on, okay? Have you got any family or anything you want us to contact?
My parents, I guess.
Okay. We'll see if we can find the next of kin details for you, all right? And then try and give them a ring, okay?
Ben, I'm doing what you look for you, okay?
Yeah, fine. Hey, all right. Vascular, yeah. So minimal sensation, but no motor function. And then he's got what appears to be a grade 4 liver injury.
I'll speak to my consultant now.
Okay. Okay. He might need to go for life-saving surgery tonight to try and A, save his arm, and B, potentially stop him from bleeding out into his chest.
My right hand's bleeding now.
Yeah, so you've got an injury down that side.
Yes.
Right.
So a really important thing now is to get hold of his family and for them to come in and try and give him some moral support as well.
Looks fairly regular, doesn't it? But that rate of 185.
Where are we going?
Fallen off a horse. Observations stable.
At the beginning of the first 3 months of this year, I noticed that when I was bending down, that there was something digging in me. I thought I'd better mention it, and then they discovered that it was a tumour. But I wouldn't have responded to chemotherapy, so my only option is that it comes out. But I'm going to lose quite a bit of my stomach as well, so.
Today we're operating on Nigel, and he's got a rare stomach tumour known as a GIST. If we leave this alone, it will inevitably get bigger and undoubtedly pose a risk to Nigel's life. Hi, Miss Brammer.
Hi.
So, as we discussed on Friday, and I'll just go over things, we're going to obviously make a cut in your belly, have a look at the tumour, and assess what we need to do.
Mhm.
And this may well be a partial excision, or more likely it'll be what we call a subtotal gastrectomy, where we remove 80% of your stomach and join things back up again.
Just wondering, the liver, we're going to find out whether it's touching that one.
Yeah, we'll find out at the time of the operation, really. We'll have a far better idea once we're actually in there as to exactly what we're going to do.
Mm.
So the risks that we discussed are things such as bleeding infection, clots in your legs, and that's why you've got these lovely stockings on.
Men in tights.
The main one to be aware of is the risk to your life, okay?
Right, okay.
We have no choice, and the benefits of this operation outweigh the risks. If you're happy, I'll obviously just confirm the operation today, and I'll give June, your partner, a ring afterwards and let her know how it's gone.
If you would, yeah,
Of course I will.
appreciate that.
We've got worries that the fracture itself has damaged the blood vessels in his arm. My immediate thing was actually, is there a viable blood supply to this arm, or are we just thinking they're going to have to take it off at the shoulder? I'm most worried about his arm than I am about what's going on in his chest and abdomen from a bleeding point of view. Because we're not happy with getting a proper pulse down the bottom end. We'll give him contrast, which is a radio-opaque dye that shows up on the radiation. We can follow that down the blood vessels and check that it tracks all the way down his arm. Must have been mortally sore overnight. Never felt to be amazed what people can put up with. I don't find some contrast down there. Contrast down the arm usually means that that's where the blood's going, because that's what's taken the contrast. So from our point of view, it's encouraging that it looks like there's at least a little blob of white all the way down the arm. So some blood's getting through.
But nothing major in the chest.
Okay.
Liver is okay. Spleen okay, some simple renal cysts, no trauma or laceration in the kidneys.
All these solid organs are pretty good, eh?
Yeah.
No delayed imaging though?
No, thank you.
Well, thanks.
No worries.
So the scan's showing us that he's got contrast getting all the way down his arm, which means he's got a decent and viable blood supply. So that's a big plus from his point of view. Now what we need to try and decide with our orthopedic colleagues is what they're going to do with this arm of yours. I think that's going to involve me making you a bit sleepy to do that. Because were it me, I'm not sure I'd want to be awake. Well, not entirely awake anyway. We'd want the bone away as soon as possible because the longer it's out of the body, the more prone to infection it is. He's got the potential to develop septicemia from this, which could be life-threatening. Right, I'm going to give you the medicine to make you feel a bit sleepy now, Alan, all right? For me, treating elderly patients, it adds a level of stress because they handle serious illness and serious trauma less well. They have less reserve, they have less in the batteries, which ramps your worry up as a clinician because you know you have less margin for error. Give us a big breath, Alan. Good lad. Like trying to stuff a button back through a buttonhole at the moment. Alan?
Hitched against that. Okay, yeah, let's put some balls.
Are you happy from your point of view where you are?
Yeah, we're happy.
Yeah,
If you want, we could.
Good. From here on in, I'm imagining what they're planning to do is surgery tomorrow whereby all of that will get properly opened up, properly washed out under theatre and stuff pinned and plated back together. Bone gets very unhappy when it gets infected, doesn't it? It then tends to vanish very quickly, never to return. So you want to try and avoid that at all costs so that you don't end up with problems with long-term infection and things like that. You all right, Alan? It's all done.
Hi, sorry. It's Julie, the doctor that saw you. We can sit you up now.
What have they come in with? The urgent blood transfusion. Okay.
You got a cut in your leg on the right side.
Sorry. So was she in it when it rolled?
Are you ready?
Okay. How long will you be? Okay. All right. Lovely. Thank you. Ta-bye. So that's a 56-year-old lady, 65 miles an hour, head-on collision with another vehicle. She's then rolled the car once. She's got pelvic pain, C-spine, T-spine pain, right hand injury. They've put a pelvic binder on. BP's 16392, GCS 15.
Set up for the trauma in 1 if that's okay. Thanks, Mel.
Trauma alert. Category 2.
Did it do a handover?
Guys, are you ready to hand over?
What's her name? Hello, Susan. My name's Diane. I'm one of the consultants. I'm just going to have a chat with the paramedics about you and then we'll get you off that board and get you a bit more comfy, my darling. All right, you're safe, okay? So,
this is Susan. She's 56, driver of a Renault Capture car. Says that she went to overtake a lorry, another car coming this way, head-on collision. Her car flipped, was found face down on the floor.
Yep, there we go. It's back together now, if that's easier. Yeah, it's together now.
She's complaining of pelvic area pain, so she has got a pelvic binder in situ. She's also complaining of reduced sensation on the right side. She's had 1 gram of TXA. Yeah. She's had 10 milligrams of morphine. She's had 1 gram of paracetamol. Perfect. Past medical history of asthma, cervical cancer, and arthritis.
So let's get her hooked up. We'll get the primary survey done. That's going to be me.
so we're just going to get you off this board, my darling, all right? Pain-wise at the moment, where's hurting?
My knee.
Yeah. And so your
neck. Yeah.
So your neck and your back and your knee at the moment. Are you able to take a Big deep breath in. Does that feel okay to breathe, or are you sore? Where does it hurt?
Here.
On your tummy.
Yeah.
Okay. Right then. So I'm just going to pop this on your finger, my darling. All right.
Oh, that one hurts.
That one hurts.
Rest your arm
Okay.
down. Rest your arm down. Almost finished here.
Head-on collisions have typical injury patterns, especially when they're at speed, and the faster they are, the worse they are.
She's just going to get you some pain relief so we can get you a little bit more comfortable, okay?
So we always expect the worst because you don't want anything to be a surprise. Predominantly at the front of my mind is the likely life-threatening injuries that we need to find quickly and deal with immediately. Are you sore here at all, darling?
I've had 2 hip replacements.
You've had 2 hips done, have you? Are you able to lift your toes up towards the ceiling? Are you able
Not
to?
really.
Oh, sorry, my darling. Where does it hurt when I do that?
My back.
Hurts your back. Sorry, darling.
Maybe because of her hip replacement, or she's got pelvic injury.
She's a little bit bent that side as well, though.
173/94.
Okay, perfect. Somebody that comes in with Susan's mechanism of injury, it's always quite surprising that they're actually even alive, let alone talking to you in the bed. But I think when patients are in pain, it can make the diagnosis of all of the injuries more difficult. It can distract the clinician, so you have to make sure that you have a thorough, detailed run-through of the whole of the patient from the word go. She is quite sore, like genuinely quite sore. She's going to need a full trauma scan. Particularly worried about her pelvis. Legs are a little bit equal. She has those previous hips, so not sure. We'll get through the scanner and work things out. All right, my darling, is there anybody that you want us to call?
My daughter, Lauren, but I can't remember the number, it's in my phone.
Okay, you'll be all right. Okay, we'll get you sorted. All right, sweetie. A serious injury to the pelvis can be life-threatening because the pelvis itself is surrounded by lots and lots of blood vessels. Any damage to the pelvis at all can disrupt the blood supply. That can be enough for somebody to bleed out.
You just want to do an IND?
Breathe normally.
So airway's fine. Aorta fine. No pneumothorax. No blood in the chest. The spleen looks okay. Pelvis looks all right. No blood in the pelvis. And have a look at the rest next door, okay?
We pick up all the sort of life-threatening injuries on the first scan. Everything else looks okay, apart from this possible fracture to the long leg bone. So the bone beneath it looks like it might be broken. So if there's sort of injuries to the lower arms, lower legs, and we can't catch it on CT, then we'll take them back and just do plain x-rays to get a bit more information. It would be very difficult to manage because she's already got a hip replacement that side, and the hip replacement goes right down into the femur, so it's a complicated fracture and they're difficult to heal.
My name's Evelyn, this is Beatrice. So we've just got a few x-rays to do, okay? So we're going to start with your pelvis x-ray first, okay?
As you are, breathe in. Hold your breath in there. And breathe normally.
You okay, Susan? We're just going back now to research.
So it's as we suspected, and as the CT said, there's nothing obvious within the thorax, abdo, or the pelvis.
But the x-rays confirm that there's a likely injury to the femur itself, and just down at the very bottom of where her hip replacement finishes.
Yeah, she's really lucky because not only did she have a sort of high-speed head-on collision, she also flipped and rolled the car and sort of crawled out through the window. So yeah, she's incredibly lucky to be alive, to be honest. So if she gets away with just having a small crack in the femur, then she's a lucky lady that needs to buy a lottery ticket, I would say.
let's give you some more painkillers, all right?
Yeah.
Giving you the good stuff now, all right?
Okay.
Sorry.
Nothing left. The treatment-wise, hopefully some good can come of this, and potentially he can make a difference to multiple other patients who are waiting for organs to save their lives.
Okay, all right, thank you. Bye.
They're coming here.
Yeah.
Take him in here, see what it looks like. Just close the doors. I've got a 65-year-old for you, Bob, who's had a cardiac arrest. They've been given 5 shocks. We need to find out the cause of why this patient arrested, stabilise and treat as quickly as possible so it doesn't happen again. Do you know what's happened to you today? You've had a very, very close brush with death.